Thank you very much, Chairperson, and thank you, Zaza and Dan, for the invitation to give this talk. Pulmonary hypertension by itself is a large, I would say, exponentially growing field in cardiopulmonary medicine. And I'm proud to say that there are many well-established clinics now in Israel, as in my hospital as well. And Israel itself is a key player in many studies and trials that are ongoing in the pulmonary hypertension field. With respect to cancer patients, the knowledge is quite limited because it is based on very small case series and case reports. So we have a lot to do more in that aspect. I encourage you to be familiar with a few of the important guidelines that were issued by the ESC that relates to my talk, the guidelines that were issued in 2015 for the treatment of pulmonary hypertension, the 2016 position paper on cancer treatment and cardiovascular toxicity. Also an expert consensus for multimodality imaging in adult patients during and after cancer treatment, recommendation for cardiac chamber quantification by echo, again, also by other modalities. And finally, a position paper on how to treat acute right ventricular failure, as many of these PH patients deteriorates with right heart failure and it succumbs into death. I'll elaborate a bit on pathophysiology related to cancer and PH, diagnosis and follow-up, and management of these patients. I'll start with a case study, a 67-year-old female with multiple myeloma. She also had primary biliary cirrhosis, which can lead, to portal hypertension. She went through autologous bone marrow transplantation, was given few medications also. In 2015, she had an echo study that showed normal systolic LV function, mild diastolic dysfunction, and her estimated systolic PAP in echo study showed 35 millimeter of mercury. It's kind of borderline or the upper norms of pulmonary pressures. In 2017, she suffered from ephrodyspnea with heart or WHO classification of kind of 2. Her echo study at that time showed normal systolic LV function, already dilated RV, moderate TR, and her estimated systolic PEP was over 100 with small pericardial effusion. Unfortunately, this patient died during the diagnostic workup. But for us is the question, what was the differential diagnosis of pulmonary hypertension that went up to more than 100 millimeter of mercury? So basic knowledge, what's pulmonary hypertension? It's a hemodynamic and pathophysiological condition that's defined by cath. That you take patients to the cath lab with a mean pulmonary artery pressure of more than 25 millimeter of mercury at rest. For now, there is insufficient data to support the definition of pH during exercise. And when we go into the pH, and I'll talk about the busy slide of what is the subgroups or classes of pH, we have to do during the diagnostic workup and to look for the causes of the pH itself. Again, another table on that, hemodynamic definition. Precapillary pH is, again, the PAP is the mean PAP is more than 25. The wedge pressure is lower than 15. And for that, we have some clinical subgroups of pulmonary arterial hypertension, what we call PAH. PH due to lung disease, chronic thromboembolic PH, what we call also CTEPH, and PH with unclear mechanism, or postcapillary. This is the largest group with PAP of more than 25, but the wedge pressure is higher than 15. and this is mostly due to left heart disease. There are also combined features for precapillary and postcapillary. How do we assess pH? Again, we assess and we estimate the PAP by echo studies, but finally we have to perform cardiac catheterization. We have to do it in order to confirm diagnosis, to exclude other causes, to follow on the severity of the disease. We can use the cath to prognosticate and to test for vasoreactivity of the pulmonary circulation in case we consider calcitonin blockers. This is a busy slide, but very important one. I'm sure most of you are familiar with. The classification of pulmonary hypertension, the last updated was in Nice in France in 2013. I'll go over it. The first group is pulmonary arterial hypertension. It's a rare disease. Most of it is due to idiopathic PAH. We are not sure what's the mechanism, probably kind of remodeling of the vasculature of the pulmonary bed. There is a heritable disease, drug and drug-induced, and I'll elaborate on this further on, and it can be associated with connective tissue disease like scleroderma, HIV infection, portal hypertension. If we recall, the case was in a patient also that had primary biliary cirrhosis. The second group is the largest of all, the pulmonary hypertension due to left heart disease, LV systolic dysfunction, diastolic dysfunction, valvular disease, and other sorts of left heart disease. Pulmonary hypertension can develop due to lung disease by itself, due to COPD, interstitial lung disease, sleep disorder, breathing. Another group is the CTEPH, chronic thromboembolic pulmonary hypertension, that progress from what we call kind of regular PE into chronic disease with fibrous tissue in the pulmonary bed. And finally, we have a PAH with unclear multifactorial mechanism that includes hematological disorders like chronic hemolytic anemia, myeloproliferative disease, patient post-splenectomy, and other disorders as well. There are some potential scenarios that we can have in patients with cancer and pulmonary hypertension. The first of all is a patient with cancer who develops pulmonary hypertension. So it can develop class 1, which is idiopathic or due to drugs, and I'll speak about the drugs in a minute. Class 2, that is associated with left heart disease. We can recall that many cancer drugs can cause cardiac toxicity to the left heart, and with that progress into pulmonary hypertension. Class 3, pneumonitis or fibrosis and parenchymal injury due to radiation and other medications. CTEPH, PE that progress into chronic thromboembolic pulmonary hypertension. An unclear mechanism such as hematological disorders and bone marrow transplantation. Again, this comes from very small case series and the mechanism is not yet clear. We can also have a scenario of patient with pre-existing pulmonary hypertension who can develop cancer as well. And then we have to treat all these patients. So PH associated with left heart disease. There are some, baseline key risk factors for this cardiac toxicity, like coronary artery disease, hypertensive heart failure, dilated cardiomyopathy, restrictive cardiomyopathy, patient who got previous or current cardiotoxic drugs like anthracycline and radiation to the chest or mediastinum. There are some demographic and other risk factors like age, family history of premature cardiovascular disease. And again, all this left heart disease can cause, this is the largest group of PH patients actually. So it can cause PH or deteriorate into PH. As with respect to chemotherapy drugs, there are some drugs, about anthracycline, the adiaramycin, that can cause cardiac toxicity with cumulative doses. I'll speak about dasatinib in a minute, which is a small tyrosine kinase inhibitor that can cause kind of left heart disease in 2 to 4% of the patient, but also PAH disease also. The next mechanism would be pulmonary emboli that can deteriorate into CTEPH. There are some, I would say, series that show that PE can deteriorate into CTEPH up to 10% of these cases. So in the previous series, we thought it was much rarer, but now we know that it's up to 10% of the cases. So there are some clinical factors that are associated with increased risk of cancer-associated VTE. The cancer-related factors like the primary site of the cancer, the advanced stage, if it is metastatic, some patient-related factors like older age, female sex, African ethnicity, and treatment-related factors that are associated with increased risk of VTE, like major surgery, hospitalization, chemotherapy-induced transfusion, hormonal therapy, and also central venous catheter that we insert into these patients. Another very important mechanism is an unclear mechanism is patient who went through splenectomy. This can cause an increased risk of CTEPH and also idiopathic PAH. It may result in loss of filtering function, leading to abnormal circulating erythrocyte, activation of coagulation, enhanced thrombin generation, as well as cytokine activation. So splenectomy by itself is related to PH. Chronic myeloproliferative disease. There are some suggested mechanisms for that. The excess risk of venous thrombosis, PE, that leads to CTEPH, and chronic myeloproliferative disease that then can cause precapillary proliferative vasculopathy. And I'll talk again afterwards on dasatinib. Another very interesting mechanism is hematopoietic stem cell transplantation. It is associated also with what we call thrombotic microangiopathy. It is well-recognized complication. And this thrombotic microangiopathy can cause PH by itself, presenting with unexplained hypoxemia. Again, very small case series, case reports that show this. Radiation, what about radiation? Lung radiation can cause pneumonitis, fibrosis, and vascular injury that eventually can cause PH. There are some histological changes in the lungs that comprise fibrosis, thromboemboli, and veno-occlusive lesions, and medical hypertrophy of the pulmonary arteries. What about drugs? In the guidelines of PH, there are some definite drugs that we know that are related to PH. There are some likely or possible connection, again, due to the small number of case reports or series that thought about causality or association with PH. So dasatinib is one of them, and also chemotherapeutic drugs like mitomycin C and cyclophosphamide are related to what we call PVOD. It can cause pulmonary veno-occlusive disease. So again, small case reports that find an association between mitomycin C and cyclophosphamide, and also stem cell bone marrow transplantation that can cause veno-occlusive disease. In this kind of rare disease, it's related to class 1. The prognosis is worse than the classic PAH. There is no established medical therapy for that, and vasodilators must be given with great caution due to the risk of drug-induced pulmonary edema. And actually, the only curative therapy for pulmonary veno-occlusive disease is lung transplantation. What about dasatinib? It's a tyrosine kinase inhibitor, drugs that is for the treatment of chronic myelogenous leukemia. It can cause often reversible PAH, kind of, when you look at the pathophysiology and you see a remodeling of the vessels. It appears few months after the exposure. And again, it's reversible after drug discontinuation, but sometimes not. There are some also reports that patients continue to have PAH after the discontinuation of the drug. So how do we manage this patient? Again, we start with diagnostic workup, medical history. It's very not specific, fatigue, exercise limitation, exertional dyspnea. Again, the physical signs are not specific. So we have to be aware. We have to think about PH when we treat these patients and they complain about fatigue and dyspnea. So we use imaging modalities, and the most available one is echo. There are some arbitrary criteria to detect pH based on the tricuspid regurg leak velocity. And it is possible when the velocity is higher than 2.8. It is likely when the velocity is more than 3.4. And from that, with the Bernoulli equation, we can calculate or estimate the systolic PAP. But again, it's not recommended as screening every day. We have to combine all our efforts with medical history, physical examination, and also the echo study itself. Again, exercise echo is not recommended for screening of PH. There are some, those of you who work with the echo, with advanced echo, there are some advanced echo parameters to assess the right ventricular failure, FAC, the D-shaped septum, systolic S prime, longitudinal strain, we heard about yesterday from Shemi Carasso, the myocardial performance index, and also 3D. Pericardial effusion, thickness, the inferior vena cava collapsibility, again, the TR peak systolic velocity, and other parameters as well. There's the advanced echo with strain, and also with 3D that we perform nowadays. How do we follow patients with echo? We perform studies at baseline, and then we perform studies every few months. And then when we change therapy, in cases of clinical worsening, we perform echo studies, and we do it routinely in our hospital. There are some strategies to reduce chemotherapy that is induced cardiotoxicity with left heart disease. Again, this is the largest group that can cause PH. So with all chemotherapeutic drugs, we can identify and treat the cardiovascular risk factor, treat the comorbidities. And I'm not going to go over all drugs, but we can give these patients ACE inhibitors and ARBs, beta blockers, statins. Again, this is for the left heart, but that can lead to PH by itself. What are the strategies for surveillance and management of drug-induced pulmonary hypertension? At baseline, we consider risk factors. We perform 6-minute walk test. We perform some blood tests that includes BNPs. And again, for surveillance and follow-up, we perform every few months. We ask the patient, we call them to the clinic, we assess the New York Heart or WHO class, functional class. We perform echo studies. And then if we need, we move further on for right heart cath, and sometimes we may consider interruption of cancer therapy. My most important message is the multidisciplinary team. The discussion should be held with the oncologist, the hematologist regarding the risk-benefit ratio of each drug and each treatment that is given to these patients. We may need to stop or replace the drugs. And again, we need sometimes to use, as Michael Arad showed, that we may use PAH therapy temporarily or permanently in these patients. And to summarize, there are some specific drugs for PAH. In rare cases, we use calcium channel blockers, endothelin receptor antagonists, phosphodiesterase type 5 inhibitor, guanylate cyclase simulator, prostacyclin analogs, and receptor agonists, Ambrisertan, bosentan, mesisentan are endothelin receptor antagonists. There are some phosphodiesterase 5 inhibitors, guanylate cyclase stimulator, like sildenafil, tadalafil, sildenafil. I'm going to finish in a minute. Riociguat. Also, prostacyclin analogs like epoprostenol, iloprost, treprostinil. And last but not least, CTEPH treatment went through from no treatment to surgical treatment when we removed this fibrous tissue. Nowadays, even in Israel, we perform balloon pulmonary angioplasty, and we can give medication like riociguat for these patients. So my take-home message is the last slide. Pulmonary hypertension is a rare but serious complication in cancer patients. The pathophysiology is multifactorial. Non-invasive cardiovascular surveillance should be considered in all these patients. I think all of you will have to refer this patient to specialized pulmonary hypertension clinics, and multidisciplinary team discussion should be held in all cases. Thank you very much for attention.
Thank you so much. Any urgent question from